All right, good morning, everyone. Happy Friday. Thanks so much for joining us today for the COVID-19 Virtual Research Seminar Series. My name is Melissa Rogers. I'm Associate Director of Business Development and Industry Relations at the Mesh Academy at Keck School of Medicine. Our mission at the Mesh Academy is to connect and to collaborate, and we hope this series does just that. So today, let's see here. All right. So today's seminar is titled Staying Current During a Pandemic, Keck's Evidence-Based COVID-19 Summary. So we have had a change to the original program. Unfortunately, Dr. Paula Cannon isn't able to join us today, but we still have 5 great speakers. For our format today, we're going to have our speakers present their presentations, and at the end, we will have a Q&A session. And this time around, we are going to use the raise your hand feature. So if you do have a question, go ahead and hit that button. And when we get to Q&A, we will be able to unmute you and you'll be able to ask your question directly to the speaker. We're also recording the webinar, so that will be available later today. So we have a really great program today. It's my pleasure to introduce our speakers. So we'll be hearing from Dr. Michael Hochman. He's Director of the USC Gehr Family for Health System Science and Innovation. We also hear from Dr. Jeniffer Kim, Research Manager at the Gehr Center. Dr. Peden, she's a clinical professor of anesthesiology and director of the Center for Health Systems Innovation. Dr. Rishi Mehta, clinical assistant professor of medicine, and he's also has the role of co-lead for Keck Hospital COVID-19 floor team. And then finally, we'll hear from Dr. Carolyn Kaloostian. She's clinical assistant professor in family and geriatric medicine. So first up, we have Dr. Hochman and Dr. Kim, so please welcome them. And I will stop sharing.
All right, so let me just share my screen here. All right, well, welcome and thanks for inviting us to present. It looks like there's been some great MESH seminars during all this, so we're really happy to be able to share what we've been doing with the Keck evidence-based COVID summary. As Melissa mentioned, what we're going to do is divide up and have several of us present, starting with myself and Jeniffer. Then we'll hear about infection control and prevention from Peden, clinical care from Dr. Mehta, and then palliative care and ethical considerations from Carolyn Kaloostian. And then we'll definitely make sure to have time for questions and answers. So let me begin by explaining what the Keck evidence-based summary is. When the pandemic was really getting going in mid-March, we got a call, myself, got a call from Dean Mosqueda, and she said, you know, there's literature coming out all the time. We're just learning about this disease. We really need a central way here at USC to compile it all and make sure we're being rigorous and not missing important issues, and how do we keep ourselves current? And she said, is there a way we could do this? Could we put together a team that's going to focus on different sections with different expertise and different faculty members so that we, you know, can make sure, as I said, that we stay current and don't miss things? And the first issue that really, I think, highlighted the need for something like this is with the hospital. We started to get some COVID positive patients, and no one knew what type of precautions should be taken in those hospitals. So there were some leaders and clinical staff who felt that, you know, we should do what's called airborne precautions, where you use those N95 masks in negative pressure rooms, similar to what we do for patients with tuberculosis or measles. And airborne spread conditions can spread for long distances. So that's the reason you need to really have a negative pressure room. The problem is there's only a small number of these rooms in the hospital. So it was going to be really challenging if that was the case. Alternatively, the CDC and many other groups were saying that coronavirus is spread by respiratory droplets. And while respiratory droplets do travel through the air, the virus isn't aerosolized. It only goes about 6 feet, which is how far those droplets go. So it still can be spread through the air, but you don't need those N95 masks if you're standing a distance from others, and just simple surgical masks can block those droplets. You don't need the negative pressure rooms. So again, this had really important implications, and there were very smart people on different sides of the equation. And so that was a topic that our group had to take on and, try to really distill what the evidence says. And, unfortunately, the evidence, doesn't always give 100% clear answer, especially early on. I think we've mostly settled that this is predominantly spread by respiratory droplets. And if you're more than 6 feet away from others, your risk of getting it through aerosolized virus is pretty low, but there are, as Dr. Peden's going to talk about, exceptions to that. For example, if you're intubating somebody or doing a bronchoscopy, the virus can get aerosolized. And in those circumstances, negative pressure rooms and N95 masks do make sense. But I spent a little time on that just to highlight the rationale for doing this. Okay, so this was, I tend to try to steer clear of politics, but I couldn't help myself on this one. The next issue that came up was hydroxychloroquine. So early on in the pandemic, it was suggested that hydroxychloroquine might have some beneficial effects for COVID-19 patients. And many doctors, not just politicians, but doctors and public health leaders were suggesting it be used, and were actually even using it. There was doctors who were stockpiling it. They were giving it to their patients. And yet there was not a lot of rigorous evidence to support its efficacy. And there were some initial really low quality epidemiologic studies that showed that those who got hydroxychloroquine did better than those who didn't. But of course, there can be all sorts of confounding reasons for that, as you might imagine. So our group did a summary, and we looked at the rigorous evidence, and we concluded that there really wasn't any rigorous evidence to support a benefit for hydroxychloroquine. And there was actually some potential for harms. For those of you who are clinicians, hydroxychloroquine can prolong the QT interval, which puts people at risk for cardiovascular complications. And over the last 6 to 8 weeks, there have been a number of more rigorous randomized trials that have supported the initial cautious approach that we took here at USC. There's not been a clear benefit, and some of those concerns about cardiac side effects have been substantiated. Now, I won't say this is an entirely closed issue yet, but again, it just highlights the importance of being rigorous, and we likely we're able to avoid exposing a lot of our patients to a medication that has side effects and doesn't work. Although, as we know, there's still, as this cartoon highlights, there's still some lingering debate about that. Okay, another topic which has come up that our team was asked to weigh in on was face coverings. You'll be shocked to hear that there's been some controversy and different ideas about what type of face coverings are necessary, or even if they're necessary at all. I certainly was taught in medical school that the general public, there's really not any benefit to using face coverings. And in the beginning of all this, the CDC was not recommending face coverings, but in response to the data, excuse me, it's become clear that there almost certainly is an important role for face coverings, both by the general public and of course in the healthcare settings. The next question is, what type of face covering? So there's Dean Mosqueda, who's been advocating for face shields, which are a little more comfortable than those cloth face masks. Can't help it, I'm a Patriots fan. Then there's the cloth face masks. Then there's the medical masks. And the medical masks obviously are the ones that have the most data and have been most rigorously studied. But as you probably know, there's some real supply chain challenges here, and there's a shortage of these medical masks, and the CDC has recommended that these be reserved for the medical setting, which has caused us to say that there's alternatives. And then, of course, there's some folks who are pointing out that in rare circumstances, the virus can get aerosolized, and maybe we do need those N95 masks to protect ourselves from that, that spread. And again, there's major supply chain issues. And again, I would say the evidence that our group has summarized is really effectively demonstrated that N95 masks don't provide a tremendous amount of value under most circumstances, with some rare exceptions in healthcare settings. So where are we settled out on this? Our group has put together a recommendation that's going to the university, and it's still being finalized, but will likely shape the university's policy. I think it's probably going to settle out where the CDC is, that cloth face coverings are going to be the way to go in most cases, although there may be a role for face shields, particularly for people who have asthma and can't wear a cloth mask. There are a number of public health departments in the country. Oregon, the Infectious Disease Society of America is saying that face shields that Dean Mosqueda likes is an acceptable alternative, but our local LA County Department of Public Health is saying that really should be a second option because it doesn't cover the face quite as effectively as a cloth face mask. Okay, and then I forgot to put this one on there. A new type of mask that I had never heard of were called KN95, and you might even see it's been FDA approved. So these are sort of like pseudo N95s. They're not medical grade. The FDA approved a number of these. And they were based on the claim. N95 means that 95% of small respiratory particles are filtered out. But then after the FDA approved it, it turned out that 90% of the commercially available KN95 masks didn't come anywhere near those standards and probably were much closer to regular medical masks. So the FDA has revoked those. But that has not stopped many people from saying that maybe this is an alternative higher grade mask, but we're not taking away from the healthcare worker supplies. That's probably something that we're not going to recommend across the board, but is an option for those who, are compelled by some of these marketing claims that these masks do provide a greater level of protection. The last, not the last, but a topic that we're currently reviewing is fever checks. For those of you who have traveled in Asia, there's infrared fever temperature scanners when you go into airports to try to identify people who might have a viral illness and shouldn't be permitted in the country. Similarly, there's these ear infrared scanners that can identify people walking into buildings that might have a fever. So this would be just another strategy to try to keep people who are sick away out of buildings where they might infect other people. And one question that's coming up is that should we be doing this on the USC campus as people get back to work? The hospitals are currently doing it, but should we do it in our auditoriums, in our office buildings? We're working on finalizing our recommendations. Again, the punchline is that these fever screenings have not rigorously been shown to provide additional benefit aside from just asking people, are you sick? But common sense does tell us there'll probably be a couple extra people who are caught through this mechanism, but it's probably low value. So our group just sort of summarizes and distills what the evidence is, and then people at higher pay grades than us make the final call based on what we say. So that's a little background about how this came about, and I'll let Jennifer take it from here to tell you a little bit about more where you can find it.
Thank you, Dr. Hochman. So I'll be giving a brief overview of the summary document. The case sum evidence-based summary can be found on the Keck website shown here at keck.usc.edu/coronavirus. And once you go to this website, you will see at the top where it says click here at the banner. So once you do click that PDF document, Next slide, please. You will get to the front page. So we try to update this version twice a week, typically on Tuesdays and Fridays. And the latest version will be depicted here with the current date. So we had just uploaded this past Wednesday. We started this document back in late March, and we've had approximately 14 iterations since then. Next slide. The second page of the document outlines the various COVID-19 topics that are covered. Some of these topics will be covered by our speakers today. And the first section here is the What's New This Week page. Okay. So this page reflects the latest and greatest evidence-based studies that our team has found. And each study is summarized in bullet form and is referenced by a blue hyperlink where you can access the study article. We've been finding that most publications are giving full access to COVID-related articles, which has been very helpful. Next slide, please. And then some utilization statistics. So to date, we have seen 49,200 people who have reached, along with 6,675 engagements. So reach here is the total number of people who have had this summary flash across their screen, and engagements are the number of people who have liked or shared it. Next, please. And lastly, I would like to thank our colleagues and collaborators for their contributions to this summary. This is an ongoing group effort that truly highlights the interdisciplinary collaborative nature of KSOM. So we want to thank all the authors and editors for your continued efforts. So this concludes the overview, and I can turn it over to the next speaker now. Thank you.
Great, thank you so much, Dr. Hochman and Dr. Kim. So next up, we're going to hear from Dr. Peden. So please welcome Dr. Peden.
Hi, everybody. Just getting my slides up. So I'm going to talk about infection prevention and COVID-19, and my particular section is specifically related to healthcare workers and anybody in the hospital environment. So I'm not talking particularly about spread in the community. However, obviously, many of the things I'll talk about are relevant to community spread as well. Here's a bit of a disclaimer. I'm not an infection control expert. There are others in the hospital who are very busy doing their jobs, so we didn't ask them, but I'm sure they would have done a great job, obviously. So I've been reviewing some of these papers based on looking at the literature, looking at what high-level journals are flagging, and also just reading generally around the subject. And one of the interesting things at the moment is how much there is in the general news, which is referencing papers like Nature and Science. So it's a very interesting time. Please remember, particularly if you're in the hospital, to follow USC, Keck, LA County infection prevention guidelines rigorously. And I will say this is a difficult topic to cover because the evidence is changing all the time. I'm going to highlight a few things and perhaps tell a sort of progression of the papers that I've chosen to highlight. So this is the virus, and it's changed our behavior dramatically in the space of a few weeks. And as I say, things are evolving all the time. So this is the first paper I picked out to show you was a report of what happened in Hong Kong. And this was, of course, important because Hong Kong had experienced SARS. And so they had a very high levels of awareness and very good infection control measures. And I will say although I'm not an infection control expert, I did a lot of work in C. diff control in the UK as a medical director across the country for safety. And I have seen the impact of just really, really good basic measures in infection control, washing your hands, following the guidelines. So essentially, this is what happened in Hong Kong. They took a very aggressive approach, and they were reporting the first 42 patients they had. Often, in fact, although they had a high level of awareness, they didn't know the patients were positive. And those 42 patients were 413 unprotected healthcare workers were exposed to those patients initially, but none of them were infected. And they hypothesized that this was because there was this rigor around good hand washing. Also, the patients were placed in rooms with high air turnover. And because of the air changes in the room, no virus was found in the air, but it was on every surface. And that's something that comes out in all the papers I'm going to show you. This virus is on the surfaces where patients are who are infected. The other thing that of the patients they found here, 66%, so 2/3 of the patients who contracted the coronavirus were in family group clusters, and they were thought to have contracted it from sharing utensils at meals. And interestingly, some of the patients were positive, asymptomatic in their 90s. So just because you're elderly doesn't mean to say that, you know, you will necessarily show symptoms. So they really emphasize that vigilance in hand hygiene practice, wearing of surgical masks in the hospital, appropriate use of PPE in patient care, especially performing aerosolizing procedures, are the key infection control measures. And they also emphasize the fact that they had really good, whoops, how am I moving on? Yeah. That they taught staff regularly, they held open staff forums, they were very transparent, they had face-to-face education sessions, giving up-to-date information all the time, practical training sessions, and that's something that comes out across a lot of the papers and the information out there. One thing we wanted to emphasize at Keck, because we had the opportunity in California to see this coming from Italy, was to practice and simulate PPE donning and doffing. Very important. And on the website, we've put links to all the CDC articles, videos, infographics about if you are using PPE, if you are in a high infection area, then the way you don and doff and wear your PPE is absolutely essential to protect you. And then regular assessment of everybody in the hospital, of seeing how they were performing hand hygiene was performed. I mean, interestingly on this, and this is the Hong Kong measures, hair cover was optional. So that is not something in general, if you're in a high risk area, certainly the CDC would suggest your hair is covered. Next one, a recent one was a live, it's called a live living rapid review, because they're updating it all the time, of all the evidence of epidemiology of risk factors for corona infection in healthcare workers. And they looked at not just SARS-CoV-2, but COVID-1, MERS, on risk factors for infection. They looked at multiple electronic databases and studies published in any language, and looked at the association between risk factors, demographic characteristics, and administrative factors and PPE. And they concluded that healthcare workers experience significant burdens from coronavirus infection, including obviously SARS-CoV-2. The proper use of PPE and infection control training are associated with the decreased infection risks. And obviously, again, highlighting, as we know, that if you're involved in aerosolizing procedures such as intubation, I'm an anesthesiologist, then you need to be very, very careful. So in detail from this paper, they looked at data in China up to relatively now, or some time ago, the 11th of February, they found 3.8% of healthcare workers had confirmed cases. And interestingly, in Wuhan, the infection amongst healthcare workers was quite significant early in the outbreak, and then decreased, and also the impact of the severity of illness as a healthcare worker, if you contracted it, decreased over the time of the outbreak, suggesting that people did get better at understanding the infection control measures. Another study of 1,300 healthcare workers who were symptomatic in the Netherlands found that only 6% of those patients had workers who had a cough or a fever were actually positive. 2 were hospitalized and there was no deaths. In all the review, all the literature, obviously working in high-risk areas, suboptimal hand washing, longer work hours, and that's one of the things emphasized in the Italian studies. In many of the big Italian ICUs, they limited the amount of time that people could spend in PPE, because obviously as you get tireder, you're more likely to contaminate yourself. One Chinese study did not find an increased risk with high-risk procedures, But they did find that there was an association if you had a family member that was infected, suggesting not all of the healthcare workers were infected in the hospital. They could have been infected by a family member. Likewise, there was no studies on transmission by healthcare workers to family workers. So in summary, healthcare workers are likely to experience a high incidence of infections, particularly for unprotected and repeated exposures. Though often they have less severe illness and mortality because they're often younger with fewer comorbid conditions. And just as an aside from the actual infection, there's obviously, I think, evidence that depression, anxiety, and psychological distress was common. And I picked this picture on here from a picture of an image of a hospital in New York. And it's interesting to see that actually the PPE here is not being worn very well. There's a gap. So it's an example of perhaps being very, very careful with PPE. Here's another paper published in Nature Medicine where they explored the importance of respiratory droplet and aerosol routes of transmission with a particular focus on coronaviruses, influenza and rhinovirus. So basically, they detected the virus in patients breathing out, and they looked at the impact of wearing a surgical face mask on the detection of virus. And they had randomized 123 participants who were positive for some kind of virus and 123 who were not. And they got them to breathe out for 30 minutes and they measured the virus in their breath. And they demonstrated that surgical masks reduced coronavirus detection in the 30 minutes of breathing in both large respiratory droplets and aerosols, suggesting that surgical face masks would be useful in reducing onward transmission. Interestingly, although this is seasonal coronavirus, they're measuring actually not COVID-19, but they still found that those patients coughed the most. But some patients who didn't cough at all still were excreting virus. And then other individuals didn't shed much virus, and suggesting that perhaps you might have to be in prolonged contact. But the important thing is here, there was a lot of variation between individuals. And if you just look at the graphs, this is rhinovirus, and if you look, this is droplet detection without mask and with mask, aerosols without mask, with mask, and for seasonal coronavirus, the mask definitely decreased the detection. So that's an interesting paper. And, you know, I think it is this time where there's lots of different information out there. And I know Mike Hochman highlighted this study. It's actually in Vanity Fair, but a good article about maybe if we wore masks. So that I think, you know, read widely. These more commercial articles are actually usually these days referring to major studies. This is the study that had us all worried about our groceries, showing that this was the New England Journal of Medicine, showing that basically the COVID-19 survives on surfaces for a long time. And I think that evidence is still there, although I'll talk a little bit more about what the CDC is saying in the moment. But this, I think, for all of us reading the literature, scared us a bit. And I certainly, after reading this, got very intense about wiping down all my plastic surfaces and groceries. Here's another one from Nature about aerodynamic analysis of SARS-CoV-2 in 2 Wuhan hospitals. Basically, they did a lot of sampling. In one hospital in Wuhan was a high-risk, severe disease hospital. They're both completely COVID-19 hospitals. And the other one was a field hospital. And they sampled in lots of patient areas, ICUs, coronary care units, and normal ward areas. And then they sampled in medical staff areas and public areas, and looked for different aerosol types. And basically, the concentration in aerosols detected in isolation wards and ventilated patient rooms, key being ventilation, was very low, but it was elevated in small confined areas, such as toilet areas. The level of airborne virus in the majority of public areas was undetectable, except where it was very busy. And in some medical staff areas where staff sat down, and often if they took gloves off, there was initially some levels of virus, but they were undetectable if there was good cleaning. So the answer there is, as you would expect, in high-risk patient areas, as long as there's good cleaning and ventilation, the risk is relatively low. But in areas where there's not good ventilation, you have to be careful. And also good cleaning of staff rooms where staff who are working with coronavirus patients are. This other one, a similar thing, also from China, featured on the CDC, in the journal and on their website. Again, sampling, almost all positive results were in areas where, you know, there was a high risk, so ICUs and general wards with COVID patients, much higher in the ICUs. There was a lot of the virus on the floor because it tends to settle with gravity, and it's tracked all over the floor, including 100% rate of positivity in the pharmacy where there was no patients. Half of samples from the soles of ICU medical staff tested positive, suggesting that you should be cleaning shoes or leaving shoes in the high-risk areas. The other thing that I think we should all be aware of, if you're in an area with COVID-19 patients, is that computer mice was 75% positive, trash cans was 60% positive, handrails of the beds were positive, doorknobs, and also virus on the sleeve, cuff, and gloves of medical staff, highlighting the need for good hand washing. So that's interesting because just yesterday, the CDC says coronavirus does not spread easily on surface objects. So I think they're trying to, the suggestion was in the media that they're trying to manage people's concerns about this. But I think we should still, certainly within the hospital environment, be very, very careful about hand washing and looking out for fomites, i.e. objects that can be contaminated. Finally, I'd just like to say, outside of the evidence-based literature, I found watching some of the more, the talking heads, if you like, of people who've had first-hand experience. Maurizio Ciccone, an old colleague of mine from the UK, is now head of ICU in Humanitas, and he did a really fantastic interview on JAMA with the editor, and I would really suggest you watch that because he talks from about the middle part of the interview on about the importance of doing the basics really well, the importance of doing your PPE properly, the importance of hand washing properly, and also of limiting the amount of time people spend in PPE. And he was named one of JAMA's healthcare heroes of the COVID-19 pandemic. So really, again, looking at some of these interviews and guidelines from major societies where there are collating a lot of experience at the moment is very important. So the answer is, I think it's complicated, do the basics well, read a lot, and look at a lot of different sources. Thank you.
Okay, thank you, Dr. Peden. I'm gonna take over now. We're gonna move along, knowing how you can get it and how you can prevent and do your best for infection prevention is a good segue to clinical care. Now, some of us were joking about whether or not each of our talks could be an hour long. So I will go through this as best as I can and as fast as I can, given our time. But I think that it goes without saying, clinical care definitely is a large scope. And first few slides, just repeating some of what we've already heard here. So this is a quote from Dr. Osler. He's considered the father of internal medicine, the field that I'm in. And essentially, he says here that a good physician should be reading all the time. And so the reconciling of two truths that I wanted to point out is we're constantly being told to read and keep up, but at the same time, the other truth that we have to reconcile is we're drowning in information and starved for knowledge, meaning there's just so much out there. And I think this was very much true before COVID, and perhaps is even more true now in COVID. Just a few things to show that almost every day, breakfast, before you see a patient, and then while you see a patient, there are many truths out there. And I think we've already kind of pointed that out with Dr. Peden's talk. And I think for everybody listening, the best thing that we've been trying to do is balance robust medical evidence while handling misinformation, but acknowledging there's emerging evidence and standing on the shoulders of, and I'll let you decide the adjective there, but or noun, but essentially documents like the one and the living document that we're all a part of is a good step in terms of trying to sift through the evidence. So in terms of clinical care, I'm going to spend about 10 minutes talking about presentation, stratification, and treatment. And I think it goes without saying that for presentation, the early literature is what really helped us clinicians figure out what's going on, whether that was from the American or the British, from Lancet or New England Journal of Medicine, or larger journals that cover both the English and the American side, but beyond just internal medicine, JAMA, BMJ, and then Nature. We had articles coming out really early in February and January talking about the clinical features, and then in March, probably more refined articles, and then of course Nature being a fairly robust journal, being able to kind of consolidate and look through and really tease out what we need to know. And so what we know is that there's a variability among presenting symptoms, and what generally brings them to the hospital, however, is this triad of fever, cough, and shortness of breath, with fever reported in 80% at some point during hospitalization. I think it's important to recognize that 50% only have it at admission, and that's likely due to the fact that the fever itself is intermittent. And then the shortness of breath, you see this variability from 14 to 60%. That has a lot to do with the fact that different hospitals have different criteria for admitting. And for instance, at the USC Keck hospital, it's different from necessarily LA County where there's an ER. But at USC Keck hospital, we do have our outpatient doctors try to encourage patients to stay at home if they only have a fever and cough, bring them in once the shortness of breath. So that accounts for that. And then of course, less commonly symptoms such as fatigue or other URI type symptoms. And it's good to point out that this clinical presentation of COVID-19 is varied in the sense that 80% are non-severe and can be managed at home. And then we really only see about 20%. And as we test more, those numbers are going down, but about 20% who require hospitalization. And so just as I pointed out, we have the literature that we start from, and then we have emerging clinical evidence coming out from various journal articles, and whether those studies are strong or not is hard to tease out. But essentially, as the weeks and months went by, GI symptoms started to be presented a bit more. Earlier stuff said that there was very little GI symptoms, but a study came out early March that argued that 50% of the patients in this one study had GI symptoms. However, again, such as Dr. Peden pointed out, it's very important to look at these journal articles for what more than just the abstract. And actually, if you look at the journal article, they broke down GI symptoms as anorexia, diarrhea, and nausea. And really, a lot of us clinicians don't find anorexia, which is the medical term for decrease in appetite, as a GI symptom. And if you took that out, then only 20% had GI symptoms of diarrhea and nausea. So this is just an example of when an article can make you really think that, half the patients have GI symptoms, we really need to watch out for GI symptoms. It was a lot less than that. Similarly, ENT symptoms started to emerge controversially. We had a largely anecdotal study that basically used a questionnaire weeks after patients were discharged with a small sample size of 59, and found that 33% had reported taste or olfactory disorder prior. And I think that this is something that as clinicians we get confused about and concerned about, because URIs like the influenza or the common cold often have a stuffy nose and changes in taste and smell. And so was this really a preceding symptom or something else? So this is an example of then as April and May came around, we actually had some recognition of these symptoms as they were actually found to be teased out a little bit more. A large UC San Diego study really looked at over 1,000 patients and found through their statistical analysis that loss of smell or taste actually was 10 times more likely to have COVID-19. And since the CDC had long stated that fever, cough, and shortness of breath were the main symptoms, and that dictated testing, they actually revised about 3 weeks ago now their guidelines and added a few things like shaking and muscle pain, but important to note that they added the loss of smell and taste. And to me, that's a great example of when the evidence emerges, there's rightful suspicion until stronger, robust, more evidence comes out. And this is happening again. So just as with the GI symptoms and the ENT symptoms, now we're getting some case reports of patients presenting with just pulmonary embolism. And we had a large, small case series of about 5 patients that came out of New York City where patients presented with a large vessel stroke. Now, the authors found this to be very well worth presenting because from their point of view, they had found that on average, young people presenting with stroke was on the order of 1 to 2 a month, and they got 5 within a 2-week span. But it really goes back to, is this robust or not? And there's been a large debate in the academic world whether or not stroke among the young is something that we should be looking out or when a young patient presents to the hospital with some altered mental status that normally we wouldn't always reach for a CAT scan of the head or not. And just as with ENT symptoms, there's some more robust evidence coming out suggesting that patients that have COVID-19 are at a higher risk and with a poor prognosis of developing clots in their body. And so the evidence still needs to be teased out, but as we've gone from February, March, April to now almost June, we can definitely recognize that beyond the respiratory symptoms, there are mild GI symptoms, there are mild URI type loss of smell and taste, and now this idea that patients may have no other symptoms besides clots. So going forward with clinical presentation, wanted to touch again on the fact that as 80% of our patients likely can stay at home and 20 come in the hospital, it's a similar breakdown in terms of severity. And this I really only wanted to touch on briefly in terms of the clinical course. And it's a very intense graphic, and I'm not going to spend too much time on it, but I wanted to point out that when a study comes out and shows things like this and more studies smaller in scale support it, it's very useful for clinicians to use, because primarily what you see on this slide, I'll use my laser pointer to see if I can try to help everyone orient here, is the top area is survivors, the bottom area is non-survivors, and these are patients that stayed in the hospital from the moment they had fever and cough on day 1 to the moment they were discharged on average day 22. And this slide basically highlights that the majority of patients, when they developed fever and cough, took about 6 days for them to get dyspnea, shortness of breath, and then another 6 days for them to either decompensate and require the ICU, perhaps get intubated or not, and unfortunately passed away, or decompensate and then find themselves improving to discharge. And like I said, I could spend a very long time on this slide, and I intentionally don't want to, but wanted to point out the fact that this is a predictable disease in terms of its clinical course that raises a lot of suspicion among clinicians. But as evidence has come out, this initial Lancet article from February, March has actually proven to be true. And as we talk about clinical course and presentation, it's important to note that, again, just like early we relied on a lot of the literature from China, we were very nervous in America as patients were starting to entering our hospital doors in terms of the mortality rate, because China, they were reporting an almost 100% mortality rate if they were intubated. But as we produced our own literature and our own evidence in America, we have found obviously that the intubation mortality rate is closer to 60 to 70%, even 50% in just entering the ICU. And so in America, our evidence has been a little bit better in that sense. Complications, won't spend too much time here, and I know in our next speaker will touch on this briefly, but there are many different causes of death for these patients, everything from ranging from ARDS to a cytokine storm syndrome that leads to that ARDS, as well as cardiac issues that are associated with that. And we're seeing some neurologic complications, as I mentioned, stroke. And there's also some evidence that the clots that I mentioned earlier as presenting symptoms may be a large component of the respiratory failure. Recovery is something that is constantly being studied. A lot of our earlier studies were on treatment and management, and now we're finding that patients that go home, it's hard to decide when to tell them to stop isolating. You swab them, oftentimes they're still positive from viral shed that's actually died off virus. And at the same time, they go home and they're no longer infectious, but they still may have symptoms. And so a recent article came out discussing that patients are having symptoms far longer than people realize, up to the order of 2 to 4 weeks. Risk stratification and treatment is going to be my next two sections, but given the time restraints, I'm going to try to go through this fairly quickly. And so, as you probably have seen in the news, we've had some early studies coming out of China, and then a better meta-analysis towards the end of the Chinese, Korean, Italian major outbreaks. It really highlighted that older age, coronary artery disease, and males were the patients that were the most at risk to require a hospitalization. This was then mirrored in the United States with our own evidence. You can see with this red box that while patients that require hospitalization really can spread the gamut of age, it's the majority in this yellow box that you see that that require ICU and unfortunately pass away that are in the elderly age above 65 population. And one thing that became very interesting from the middle of April to now is that journal articles were coming out suggesting that obesity was an independent prognostic indicator requiring ICU and even death. And again, as we were highlighting here in our talks, the evidence has then been reflected in US data showing that while hypertension is the #1 comorbidity in hospitalized COVID-19 patients, obesity is actually #2. Something that's also grabbed the headlines over the last 3 to 4 weeks is racial disparity. And this is an example of where we still don't really have robust evidence-based medicine that really points towards race as an independent risk factor, but we do have epidemiologic studies that are coming out from each state, Louisiana, New York, I touched on County of LA. And again, these aren't age controlled, and so it's hard to make a lot of generalizations, but in terms of the CDC and what they've reported, they have definitely shown that while the population of the United States is 14% Black, 33% are dying and recovering, hospitalized with COVID-19. In the last 2 minutes, wanted to touch on treatment, but as Dr. Hochman pointed out, I think that this is a section that causes a lot of controversy and debate. And so I try to keep it with really only highlighting hydroxychloroquine as sort of a template for actually how all the meds have been studied. So we know that we want to try to target the virus with antivirals, and hydroxychloroquine was one that, fortunately or unfortunately, depending on your view, really grabbed the headlines from the beginning. And let's talk briefly as to why. There was a randomized trial, but I point out it's not yet peer-reviewed still to this day or published, that showed that time to clinical recovery and radiographic resolution was improved with hydroxychloroquine. And another randomized trial, also not yet peer-reviewed, not yet published, that showed a negative conversion rate, although it highlighted that there were higher adverse events. And so just as Dr. Hochman and Peden pointed out, important to balance these kind of things with more robust evidence. And so we have studies coming out from JAMA, New England Journal of Medicine, not yet randomized, but large observational studies, large retrospective studies that show no reduction in risk for mechanical ventilation, no change in mortality, nothing associated with intubation and death when you use hydroxychloroquine. I wanted to touch on that pendulum just to point out that the next pendulum could be this medication. The trade name is Kaletra. It's an HIV drug. Early in the COVID outbreak, there was suggestion that in New England Journal that severe cases did not improve from Kaletra. But now there's a study that came out in the Lancet that showed that combining this med with other antivirals actually had benefit. Remdesivir, again, I could probably spend an hour on remdesivir, briefly like I did with hydroxychloroquine, but I'll just point out, and that abstract is meant to point out that there could be a new pendulum in the sense that there's earlier study that suggests it doesn't work, and then obviously we all know it got FDA approved because it's starting to work. Evidence is showing that it's starting to work, but again, it's not been published yet. It's been data leaked. And then there's other targets, immunosuppressants, convalescent plasma, and studies are coming out, mostly case series, pointing towards their benefit. And I wanted to highlight that while we don't really feel that we have a grasp on how to handle these medications, because it takes quite a bit of time to do randomized control trials, it's just important to point out that we have to just use reason when we use these meds, balance the risks and benefits, and that we've had outbreaks in the past and there are history lessons. This is a nice graphic that highlights where all these medications target. I encourage people who are interested to review this article. It's a New England Journal article that really goes through the review. And just handling all the misinformation out there, I wanted to point out there are 203 different types of therapies being reviewed right now, and that's part of the problem that as clinicians we face. So with that, I'm going to turn it over to my colleagues in palliative care.
Thank you. That was excellent. Everyone could hear me? Great. So thanks for this opportunity. We are on the home stretch here. Final portion is going to be about palliative care and ethical considerations. I am a geriatrician with some palliative training. I am not an ethicist. So again, a review of the literature. And a lot of it is what comes from the past and what we've learned. So the objectives here will be to understand a shift away from maybe patient-centered to population-centered ethics during a pandemic, review of the role of palliative medicine in supporting patients, their families and care providers, review how the pandemic impacts advanced care planning discussions, and review a few of the ethical considerations, just a few, because there are many during this pandemic. And so why are we talking about palliative care? It's a holistic approach to suffering, both physical, existential, psychosocial, during serious illness, providing support for patients and their families. We have an obligation to provide good symptom management to all patients. During a pandemic, when resources are stretched and potentially life-saving treatments are not offered, it is even more important to offer comfort and palliative options. In a pandemic, we potentially face a shortage of these resources, including personnel. When appropriate, there is a shift that's needed, from patient-centered ethics to how we can help the most people, the whole community, a public health focus. They might not be getting treatments that they would have gotten before this pandemic. So there is also a shortage of the experts and personnel like palliativists. This is expected. It's already we're already in short supply. And so there's preparations that are needed to train as many people as we can for this very important and needed skill set. And so perhaps leaving these expert palliativists to work on some of the most challenging cases. I keep saying when appropriate, and I think it's important to highlight that in pandemics, there's different levels. There's the usual standard care that when you have ample resources, but that can change, and can change very quickly to a contingent level, and then to, yes, a crisis standard of care. And so some of what we'll talk about is when we're in those levels of a pandemic, when the surge is high of sick patients and the resources are not enough. We have learned from pandemics of the past that we can best prepare by actually selecting a separate group, a triage committee, not consisting of frontline staff, but truly a diverse select group who help in decision-making on what to offer based on the situation at hand. Where are we in this pandemic in regards to resources? This can help support the triage, the situation, but also the moral distress of the frontline staff. So truly important. It's important to, another component is advanced care planning before serious illness comes. What matters most to these patients? What brings them the most joy to their life? What quality of life they would regard as acceptable? We want to avoid non-beneficial and unwanted care. And so having these discussions before someone's seriously ill is very important. And we've been very proactive already in this way here at Keck. Here we discuss some of the unique considerations when you're having these discussions, and just to go quickly through them. So if it comes up in the conversation, if you're admitted to the hospital ICU, you probably won't have too many visitors, and this is difficult for families. They need to know this, because they won't get this usually the same level of involvement that they're used to when their family members are ill. If they need a ventilator, it is likely to be a prolonged period, not like when you have a pneumonia and you may be on it for a few days. This is on average 3 to 4 weeks. And that's important in making these, advanced care plans, to know about that. And if we are in a triage mode, care will be based on institutional policies to know what is offered. And it's important that they know that based on what's best for the most people. And we're also in a telemedicine world. So a lot of us are doing things like this remotely through a screen. And so performing these discussions and some of the documentation involved, which already doesn't get done adequately before a pandemic. Now we're happy to hear about some relaxation of the potential of accepting verbal orders, for instance, when you complete pulse forms, as well as the documentation of some of us who are completing pulse forms see this part of and it's right there in yellow, additional orders for instruction. And we often don't use it, but I've used that in the past month more than I ever have in the 10 years I've been practicing. And so it's a place here that they're recommending the literature, that it would be instructing us that you can put that these discussions happen during crisis standards of care during COVID-19. And it's important to do that, they're saying, because later on, when that's not the situation, it may need reevaluation. There's also recommendations from American Geriatric Societies, for instance, to review and re-update advanced care plans for this time. And also we want to provide the information we know to patients from the literature, but also what we don't know, because it's important to be very transparent and honest. There was a JAMA paper, and I think it's an important point to bring up during a pandemic, that reviewed a framework for what they call informed assent. I think many of us have heard of or gone through ourselves informed consent, where they give you all the options, you know, all the alternatives, the benefits, the risks, and choose which one you would like. But this is different. In a pandemic, again, in certain standards of care levels, we may come to a place where we do informed assent, which is essentially, in times of severe shortage, you basically let patients and families know that if their situation worsens, this is what we will provide. And followed by letting them know, if you get worse, we will not admit to the ICU, and really just getting the informed agreement that this is the protocol at this time. Talk just a little bit on the evidence on prognosis. I think it's important when we're guiding discussions, particularly in the inpatient setting. And so understanding the expected clinical course and prognosis of severe COVID infections will aid in patient and family counseling, the goals of care, as well as the appropriate timing and intensity of palliative care and symptom management. And really quick, a few things from the literature on these parts. So nursing home residents, there's a case series of 21 critically ill older adult nursing home residents in Washington, mean age of 70. The mortality rate was 67%, with only 9% being discharged from the ICU. And some hospitalized patients, we had many studies, but a few to comment on were a retrospective study in Wuhan, 54 out of 191 admitted patients died, so that's roughly 28%. But then there was a bigger study, but it was observational, and New England Journal of Medicine, over 8,000 patients in 169 hospital databases, and their in-hospital mortality was near 6%. Lots of anecdotal experiences cited in the literature about development of ARDS, and if you forego or don't get a ventilator or intubated, that it's a fairly rapid decline, unfortunately, and likely death within 12 hours. For mechanical ventilation, I think this is important because I don't participate, but when speaking with Director of Palliative Care at Keck, Dr. Puri, she mentions that this is, you know, some of our most difficult discussions, especially if in the outpatient before serious illness, there's been no even broaching of advanced care planning. And so a case series analysis, and this is actually a pretty popular study we probably all saw, and it mentioned, 80% mortality. So I wanted to definitely talk about this a little bit more in detail. So a case series analysis of 5,700 patients for about a month, from March to April, reported among about 1,100 patients requiring ventilation, so a ventilator, 3% had recovered and been discharged from the hospital, but only 25% died, and by the end of the study. And so 72% were still alive in the hospital. And, the abstract and what people are taking away from this paper, unfortunately, are saying, oh, there's over 80% mortality. But really here on the second column, you see in the last two lines there that there were only 25% who died in that month, and then there were 72% still alive on a ventilator. So all we can say from this data, and so again, it's really important when you're having discussions with family members to have accurate what you know, what you don't know, as you can say that in the month of the study that 25% passed away who were on ventilators, and the mortality could potentially be higher, up to 80%, but all we can say is that it's over 25%. And then the last group, I think it's important in talking, if you do talk about heart-stopping, resuscitating outcomes of CPR, in a 136 patient study in Wuhan who underwent CPR, not in an ICU, but on an acute care floor. So that may be a little bit different, your resources there. But 13% had restoration of spontaneous circulation, with only 2% though alive in a month. and only one having a favorable neurologic outcome. So again, I think in giving discussions about if patients bring up like, you know, what would be the outcome of CPR after a severe COVID infection, that some, very little, but some of the data is showing that's very poor prognosis with that. Really quickly, just a slide for some of the new published conversation tools. So I don't know about you guys, but I haven't been in a pandemic before, and even if I have experience in palliative care, we don't have these sort of discussions a lot. So I spend a lot of time just in case being prepared. I want to be prepared. I think all about preparedness, pandemic preparedness for me, hand in hand. And so Vital Talk was one of the big websites that provided a lot of talking maps. So kind of what to say when they ask this. And why I bring that up is because there's an app on your phone. And so if you happen to get into a conversation, it's really something you could easily pick up and go to. And then there's talking maps for crisis standards of care and how to say things like we mentioned before, that this is, you know, with informed assent, and this is what we're going to do, and that we probably will not be going to the ICU. And some of the other websites here that provide different formats that you can get some of the, you know, language that you may want to use in different situations. And the final portion is, again, just to cover a couple of ethical points. I think it's important to mention just stuff from the past. So we have Ebola, SARS, influenza, TB. The World Health Organization has put together tons of guidance from the past on ethical issues that may arise during a pandemic. And so some of the principles they mention are justice, beneficence, utility, respect, liberty, reciprocity, solidarity. But I want to put, it's important to set the stage in talking about these ethical discussions. So first, it's a time of great uncertainty. Public health decisions are being made quickly. We have a deficit of scientific evidence, and it's new every day, as Dr. Peden had mentioned. There's also social and institutional disruption for all of us. The climate of fear and distrust. Health system resiliency gets challenged during a crisis. And we're weighing and prioritizing potential competing ethical values. And we need to keep in mind the vulnerable populations. With the time pressure, the resource constraints, it's forcing action without perhaps thorough deliberation, inclusiveness, transparency, that robust ethical decision-making process demands. So we need a moral compass to guide this decision-making. One of the topics that I've already alluded to was the fair, or hopefully the fair allocation of limited resources. A lot of different guidelines have come up, but essentially it's important to be fair to all parties, consistent procedures, transparent, also ideally within the same location, hospitals are doing something similar, and ensure public trust. You can do this by a few things. One, we want to adopt guidelines from the past to this pandemic that were developed with multidisciplinary teams, including representatives from the public. So World Health Organization and all the other different organizations, it's important to use those and apply it to this specific pandemic. And it came up that in other pandemics, perhaps children had poorer outcomes than necessarily here in greater amounts. And so just to make sure we adapt it. And we already talked about the second issue, which is to have a separate committee, a triage team, not the frontline staff help making decisions. And very important to mention is the guidelines mentioning using a scoring system like a SOFA score, a mortality score that will help, and not to rely on age, disability, or any marginalized group, any sort of thing like that. Really important to keep that in mind. The next issue I want to, major issue to talk about is public health imperatives versus civil liberties. So we want to all flatten the curve. We've been hearing that for months now. It's critical for healthcare system not to be overwhelmed. We do not want to see what happened in Italy or even New York. However, let's take a look at the restrictions that have been in place. Travel bans, Chinese cities locked down over 50 million people, draconian restrictions in Italy. In the US, we had safer, stay at home, and even shelter in place orders. We have to also pay attention to the potential economic and psychosocial impacts for prolonged periods, which could be substantial. And so I just want to highlight that it really is important to look at the standards placed for human rights from over 35 years ago. They're principles that have been adopted by the UN Economic and Social Council back in the 1980s, and the UN Human Rights Committee general comments on states of emergency and freedom of movement, which provide actually authoritative guidance on government responses that restrict human rights for reasons of public health or national emergency. And truly, they say any measures that are taken to protect the population that limit people's rights and freedoms must be lawful, necessary, proportionate. Also, the states of emergency need to be limited in duration, and any curtailment of rights needs to take into consideration the disproportionate impact it may have on specific populations or marginalizing groups. So public health leaders, you want the intervention to meet these standards in every single decision you make. And many times it does not, and can have then negative consequences. So think not coercive efforts. You want to ask people to not shake hands, not instead of locking people up in their homes, which we might have seen one too many times on media. And the last main one to cover was the right to try versus clinical trial. So with pressures of a crisis, our judgment of rational versus emotional tips towards emotional. We, patients and prescribers, may rely on anecdotes, personal experiences. I know in some of our team meetings, well, maybe we should, maybe there's a rationale, even though the evidence was not there. So we need to remember, randomized controlled trials are the gold standard, the only way to assure effectiveness and safety. Our oath was to do no harm. But some feel there's a rationale for a patient to try medications outside of a trial. What if they can't wait for the trial? What if their values are consistent with an alternative to getting intubated for a long period of time with high mortality rates? What if the patient understands it could cause them harm, it could contribute to their death? And what if that medicine or therapy was in ample supply, and so those who truly need it and it is effective, they have it? So would there be a rationale? And the last slide is about just the ton of other ethical concerns that came up. I just highlighted a few here, which I find important. So for health equity, a report highlights that obviously providing high quality care for vulnerable patients globally is both ethical and necessary to ensure Americans' health. But some don't have primary care providers. Some don't have health insurance. Some have a lot of distrust for our institution. They don't have access or comfort with technology. The internet, they might not have. There may be language and cultural barriers and others. So it's really important to keep this in mind during a pandemic. There's recent information about immunity certificates or passports. There's still major concerns due to a lack of scientific consensus on testing standards, inequitable access to get those testing, and even have we decided who's going to pay for the cost of making these certificates. There's also a differential impact. So those populations, there may be groups that have fallen ill more than other groups, and they'll have a higher percentage of immunity. And there's others that are following also the rules very strictly, and so there's very minimal immunity there, and so they won't have the benefits of others. So just to understand the differential impact that brings. And the AMA has done an incredible job. So many different ethical guidance they're providing. Some of them I found applicable, student leaders graduating early. It's really important that it's safe for them and it's ethically sound process. Also providers doing remote care. We have responsibilities to uphold. It's really important to consent and to follow those guidelines. And then physicians in the media. I don't know about you guys, but we start seeing different doctors talking this way or that way. And it's really important for us to do that responsibly using the very good literature, which again, and being honest, what there is and what there is not. Just a quote. So nothing in life is to be feared. It is only to be understood. Now is the time to understand more so that we can fear less. And I still don't understand the toilet paper situation, but that's it.
Okay, thank you so much, Dr. Kaloostian. So we've run over a little bit, but I wanted to, and so we're not going to be able to get to questions, but I wanted to go ahead and thank our speakers for helping us to keep us informed. So I wanted to thank Dr. Hochman, Dr. Kim, Dr. Peden, Dr. Mehta, and Dr. Kaloostian for their talks today. And just briefly, we have our next seminar will be next week. So please join us. And if you have any questions for the speakers, you can go ahead and contact us at the Mesh Academy. So you can email Mary Bass at usc.edu, and we'll reach out to the speakers and try to get answers for you. So anyway, thank you everyone for joining us today, and we hope to see you next week. And have a great Memorial Day weekend. Thanks everyone.
Thank you.
Thank you.
Thank you for having us.